Good afternoon, everyone. This is Serena Lowe with the Office of Disability Employment Policy with the U.S. Department of Labor, and we're going to get started in just a couple of moments. I'd like to go through a couple of housekeeping items before we start our introductory remarks. The first is that we had a full number of individuals register for today's webinar and exceeded our capacity. So I want to remind folks on the phone, and please share this with your colleagues in the field, that this webinar and the webinar that we conducted last week with our colleagues at CMS are both recorded and will be available on the National Lead Center's website in the near future. Additionally, we asked folks as they were registering for today's webinar to submit questions in advance that they may want to raise in the Q&A session of today's presentation. We will try to get to as many of those as possible. You're also welcome to submit questions as you're listening to our presenters today in the chat feature. We may not be able to get to all questions today, but we will take any questions we did not get to and work on written responses so that you have that information in the future. At this point, I'd like to welcome everyone again to today's webinar. We at ODEP are delighted to host this national dialogue to highlight some great policy advancements from our partners at the Centers for Medicare and Medicaid Services. On behalf of Assistant Secretary Kathy Martinez, who could not be with us today, she was with us last week, but she is traveling today. I just want to express our sincere gratitude to our colleagues at CMS for the time that they're taking to work with us to help educate the field and state governments in particular about some great policy guidance that they've issued in recent weeks that we believe can be used in a number of systems change efforts, and specifically in our interest with respect to helping support and inform employment first state systems change efforts. As we all know, there are many parallels between the health and employment of citizens with disabilities, and state Medicaid programs play a critical role in not only supporting the health and well-being of individuals with significant disabilities, but also supporting their goals for living, working, and participating meaningfully in typical community settings. And that's why we've been working so hard with our partners at CMS to find ways to collaborate across agency on sharing information and leveraging technical resources around these areas of mutual interest. 2014 is an exciting time as ACA implementation comes in full force, and ODEP is strongly committed to supporting CMS as it works towards that implementation. We are really pleased and humbled by the tremendous efforts of our colleagues at CMS to issue really strong policy guidance that reinforces the importance of providing services funded by state Medicaid in the most integrated settings possible. Hopefully by the end of today's discussion, you'll have a stronger sense of the general overview of the final rule on home and community-based services and what constitutes an HCBS setting in the eyes of CMS moving forward. We anticipate that this will be the first in a number of webinars around this rule. Obviously, the rule has massive impacts for the work that is being done at the state level and in local governments and communities nationwide. And we anticipate there will be a need for additional follow-up webinar opportunities and educational opportunities down the road, which we are very excited and happy to work with CMS to fulfill those needs. I would like to take this opportunity now just to make a brief introduction of our two esteemed colleagues from CMS who will be our key presenters for today's discussion. First is Ralph Lawler. He is the Director of the Division of Long-Term Services and Supports at the Disabled and Elderly Health Programs Group at CMS. And prior to his time or to joining CMS, Ralph was at the New Jersey Division of Developmental Disabilities for over 30 years, and in his role as administrator there of the Medicaid waiver unit, Ralph had significant involvement in services for seniors and people with disabilities through a Medicaid state plan service delivery system in both a managed care and a fee-for-service model. So he's worked in both of those worlds. Ralph's work has also included very close involvement with the Money Follows the Person demonstration projects, and during his time in New Jersey, he led a coalition to ensure statewide coordination of all 5 1915C waiver programs that the state had at the time. So, he's really walked in the shoes of state administrators around these issues. He really doesn't need any introduction. He's been a wonderful national leader on these issues for many years at CMS, and we're just delighted to have him as a formidable partner with ODEP. His colleague, Colleen Garuder, is also joining us. For those of you that participated in the webinar last week, Colleen was our key presenter, and she is also with CMS's Division of Long-Term Services and Supports and has been there since 2011. And prior to that, she was employed by the State of Maryland's Developmental Disabilities Administration for many years and held the position of statewide coordinator for transition and employment services. So we're really thrilled again. I just again want to express my enormous gratitude to both Ralph and Colleen for their time today and their willingness to give as much information as they can at this point about the final rule related to Medicaid HCBS, and we really look forward to their presentation. So on that note, I'm going to turn it over to Ralph.
Good afternoon, everyone. Thank you for the introduction, Serena, and we, of course, want to acknowledge your tremendous work in the area of day habilitation and specifically employment opportunities for individuals. We certainly enjoy working with you, and we're pleased to see the number of people who signed on. So we'll go ahead and get started. This final rule is significant in our world, and I'm sure yours. So let's start moving through this. I'm sorry. So the final rule was published in the Register on the 16th of January this year. It is effective the 17th of March. If you look at the title, it shows you that this rule encompasses a lot of different authorities, and we'll just expound a little further. The intent of the rule, and I need to explain that this PowerPoint is not a normal PowerPoint where we do brief outlines and then give more detail as we present. So there are times when it's going to feel like I'm reading to you. That's because we wanted to make this document inclusive enough that you could use it absent a presentation. So I will apologize in advance for that, but also remind you that it is, we created it so it would be a tool after the fact. So we wanted to ensure that people in long-term services and supports have full access to community living and the opportunities to receive services in the most integrated setting. A little later on, we're going to talk about where we set the bar for that integration. We also were looking to enhance the quality of HCBS and to provide additional protections to participants. So this is important. The final rule is the combined response to public comments on the two proposed rules that were published in the Federal Register May 3rd of 2012 and April 15th of 2011. So this encompasses both the 1915C and the 1915I. Anybody who is looking for, or anybody who comes looking to you for the 1915C rule should be pointed here. If they tell you it's the 1915I rule, the answer is yes, it is both. We received in one of those NPRMs, we received up to 2,000 comments. So we received and processed well more than 2,000 comments in the process of reaching the endpoint with this rule. And I can tell you, if for anybody out there who's interested, you can go back to 2008 to see the first publication of the NPRM for the 1915I. Then there was an ANPRM for the 1915C, then the 1915C NPRM, the 1915K NPRM, the 1915I NPRM, and this final rule. So you will see the progress of public comment and where it got us to, and you should understand from this presentation today that your comments were significant in guiding the development of the final rule. The rule describes and aligns HCBS definition, the requirements, characteristics of settings across the 1915I, the 1915K, and the 1915C. So the definition is consistent for all three. It defines person-centered planning in the 1915C and the 1915I. The K was published earlier, so it is more fully developed in this rule, but it will be possible to bring the K into alignment with the I and the C through sub-regulatory guidance in the K. It also is the regulation that implements the 1915I. The 1915I changed under the Affordable Care Act. The original NPRM was never finalized, so this is your first regulation on 1915I. It provides the opportunity and the option to combine multiple target populations in a 1915C. That is significant, and that is significant for providers of day programs as well as other services. We have states that we know currently are waiting for the effective date so they can do an amendment and bring in individuals with mental health issues into some of their currently standing 1915Cs that hold individuals with IDDD issues because those waivers include significant services for individuals with mental health issues. So they will be able to access them through those waivers, and some of those services include day program services. It provides additional compliance actions with regard to the 1915C, so everyone should be aware that it is no longer does CMS approve or deny a waiver when it comes to a waiver that is out of compliance. There are compliance actions that CMS can take to assist a state in bringing a waiver into compliance short of denying individuals across the board services. It establishes a 5-year renewal cycle, essentially for those who are experiencing managed care, which is generally in a long-term services and supports environment done through a combination 1915C, 1915B concurrent. There was disconnect. The 1915B required a renewal every 2 years. The C required a renewal every 5 years. So the renewals realigned every 10 years if the state was lucky. This allows you to set a concurrent renewal process for those authorities and other authorities that serve individuals with duals. It facilitates a state's understanding and provider and individuals' understandings of what is required under a managed care system of service delivery for long-term services and supports. It also includes a provider payment reassignment that is significant for states that have collective bargaining providers that they work with. I don't think that's germane to our conversation here. We're going to talk now about home and community-based settings requirements, and they span all services, including those non-residential services such as day habilitation, supported employment, pre-vocational work. So The home and community-based settings, if you look at the original intent or the original design in the first NPRM and ANPRM, we defined home and community-based by what it wasn't. It wasn't an institution, so we defined what an institution was and said, otherwise, it's HCBS. The comments, consistent comments from across the board, led us to a different, to land in a different area. We now describe home and community-based settings based on an outcome-oriented definition, and it focuses on the experience of the individual in the setting. So, if an individual is in a home and community-based setting, their experience of life should be different from that of an individual in an institutional setting. The requirements maximize the opportunities for individuals to have access to the benefits of community living and to be integrated. That is important. Home and community-based services is not defined by what is inside four walls. It is defined by what is inside four walls and what is the access to the community and what is the integration in the community. There is established a mandatory requirement for the qualities of home and community-based settings, which includes the discretion of the Secretary to determine other appropriate qualities. There are three major areas. There are settings that are not home and community-based. There are settings presumed not to be home and community-based. And there are, in this document, there are state compliance and transition requirements. So be aware that CMS looked carefully at the state's concerns that people would be without services on March 17th, the effective date, and we have allowed a transition period. HCBS is integrated in and supports access to the greater community, which is what I've been emphasizing from the beginning and will continue to emphasize. It provides opportunities to seek employment and to work in competitive, integrated settings, to engage in community life, and to control the individual's personal resources. In addition, it ensures that individuals receive services in the community, and here is the bar we have set. To the same degree as access as individuals not receiving Medicaid home and community-based services. So their experience, both sets, should be the same. Settings are selected by the individual from among settings options. Those setting options should include non-disability specific settings and an option for a private room in a residential setting. Again, not necessarily germane to day services, but something to keep in mind for all of the individuals you're serving. The person-centered service plan documents the options based on the individual's needs, preferences, and for residential settings, the individual's resources. So in saying this, it should be clear that the person-centered plan documents the non-residential as well as the residential options. That does influence those individuals on the phone. Settings must ensure an individual's right to privacy, dignity, respect, and freedom from coercion and restraint. They must optimize the individual's initiative, their autonomy, and their independence in making life choices, which bridges that area with regard to the concern about freedom from coercion. It also facilitates an individual's choice regarding services and supports and who provides them. And I would say in the non-residential habilitation area, it is important that individuals understand their options. If they don't understand that there is an option, for instance, for employment, they're not going to select the option that they may truly want. So it's going to be important to ensure that individuals have the options and understand the options.
And can I interject for just one moment? A saying that I often give in the presentations that I do is a quote from Pink Floyd, and that is, "All you touch and all you see is all your life will ever be." And so if all people know is what's within the four walls of a sheltered workshop or a day rehabilitation program, and they've never had the experience to actually go out and see, touch, feel, and experience what a job might be out in the community, then they don't have an informed decision to make. This actually sort of facilitates the decision-making process.
And I would keep that in mind even as you're thinking about your education programs, because if an individual through an education program's only thought process for what will happen after they leave school is a programming, facility-based service, they're not going to be able to voice a preference for employment. Okay, so for for settings that are provider-owned and controlled, and these are residential settings, so I'm going to skip swiftly through these slides because they shouldn't impact you at this point. Essentially, the bottom line is we looked at home and community-based settings that are provider-owned and controlled, recognize their difference from an individual's own home and from an individual's family home, and said there needs to be additional requirements, characteristics there. And one, and probably the strongest base, is that there must be a residential agreement that allows the individual the same rights as anybody who would have a tenant agreement in that state or locale. So it's a guarantee against automatic eviction. The person gets the same process and appeals as anyone would expect in their life there. Privacy, sharing units, freedom to furnish and decorate sleeping and living units, they're all issues that are important to individuals, just as having individuals visit when you want them. So all of these are criteria for a provider-owned or controlled setting. What we did here, and you should just pay attention to it because it's important from person-centered planning process, which we'll talk about later on, is that any time an additional requirement to provider-owned or controlled settings is discussed or agreed upon, the modification must be supported by a specific assessed need for that individual, not for a disability, for the individual. They must be justified in the person-centered service plan, and they must be documented in the person-centered service plan. I'll talk about person-centered service plan a little later on. What I want to make sure you understand from a day program standpoint is that we are not looking for separation or assortment of programming based specifically on the individual's disability, but rather fashioned for the individual themselves. And that is a very important distinction. So, where you're talking about modifying those characteristics that are required, it must be a specific individualized assessed need, and I'm going to highlight these not because they're provider-owned and operated, but because they're important whenever you're working on or considering a restriction of an individual's normal life process. They must be specific to the individual. They must include, the documentation in the person-centered plan must include prior interventions and supports, including less intrusive methods. The condition must be proportionate to the assessed need. There must be ongoing data measuring the effectiveness of the modification. If the modification doesn't work, the modification must stop, and another approach must be looked for. There must be established time limits for periodic review of any modifications. The individual must give informed consent, and there must be assurance that interventions and supports will not cause harm. Okay, we'll talk about settings for a minute. Settings that are not home and community-based. Nursing facilities, institutions for mental disease, IMDs, intermediate care facilities for individuals with intellectual disabilities, ICF, IIDs, and hospitals. None of these are areas where we would consider home and community-based services. There are, if you look, several of these that have billing options for federal participation through other resources. For instance, nursing facilities certainly can bill as a nursing facility and apply for federal reimbursement, but not through home and community-based services. With one exception, and that is when the individual is on respite. And I'll be clear about that. Settings presumed not to be HCBS. So those settings are settings in a publicly or privately owned facility providing inpatient treatment. So it's both public and private. If the facility provides inpatient treatment, we will presume, the federal government will presume that that setting is not home and community-based. Settings on the grounds of or adjacent to a public institution. And settings with the effects of isolating individuals from the broader community of individuals not receiving Medicaid HCBS. Again, we're giving you the bar. It must be the same for individuals receiving services funded through Medicaid as individuals in the community not being funded through Medicaid. Now, if those situations occur, if the setting is presumed to not be home and community based, it cannot be included in a 1915C, a 1915I, or a 1915K program, with the following exception. If the state submits evidence, and that evidence would go through a public input process because the evidence will be submitted as part of either the transition plan for the waiver or SPA or the statewide transition plan. So it will go through a public review process. The state must demonstrate that the setting does have the qualities of home and community-based and not the qualities of an institution. And when CMS reviews that evidence through heightened scrutiny, CMS will make a determination as to whether that setting meets the requirements for home and community-based and does not have the qualities of an institution. This does not mean that a state looking at presumed institutional or presumed non-HCBS must submit evidence. It means they only need to submit evidence if they want to bill and they believe those conditions occur. If the state says we do not wish to bill for these settings anymore, we do not consider them home and community-based, CMS will not compel them to submit evidence. For new 1915Cs or Is, they must be HCBS and have the characteristics of HCBS before they are approved. So there is no transition period offered for new 1915C or 1915I or 1915K applications. So let's talk about transition. You may have been worried that March 17th you would lose people from day programs, or that people would lose their the activities that they attended during the day. And that would not be true. For renewals and amendments to existing home and community-based 1915C waivers submitted within 1 year of the effective date of the final rule, so that would be March 17th, 2014 through March 16th, 2015, the state must submit a plan in that renewal or amendment detailing any actions necessary to achieve or document compliance with settings requirements for that specific waiver or amendment. And the renewal or the approval of the renewal or the amendment will in part be based on what is included in that transition plan. The same holds true for 1915I state plan benefits that are either amendments in nature or renewals in nature for that first year period. So, after the first renewal or amendment of either a 1915C or a 1915I, 120 days later, the state must submit a statewide transition plan that discusses how the state will comply with the settings requirements for all 1915C and 1915I state plan services inside the state. 1915K is not included in there because 1915K is not authorized with availability of a transition plan. It should be fully comporting with HCBS upon approval. The level and the detail of the plan will be determined by the types and characteristics of settings used in the individual states. So it will be state specific, and that includes non-residential services and where the state is ready to address those issues. When a state does not amend or renew within that first time frame that we've discussed, March 17th of 2014 to March 16th of 2015, the state must submit no later than March 17th of 2015 a statewide transition plan for how all of the 1915C and I's programs within that state will comport with and be in compliance with the rule. With regard to the transition plan, the state must provide a 30-day public comment period, and they must they must provide a minimum of 2 statements of public notice and public input procedures. The thing here is those notices should reach a broad base of your stakeholders. It should not be a limited notice, which is why this request is here. It should ensure the full transition plan is available for public comment. It should consider public comments. The plan would be modified based on public comments if it was appropriate, and the state must submit evidence of the public notice and the summary of the disposition of the comments. The state will retain those comments, and CMS can review them within the life cycle of that waiver to ensure that the state did, in fact, cover all of those issues that were required through the public comment period. The plan is implemented when CMS approves it. If the state fails to submit an approvable plan or fails to comply with an approved plan, there may be compliance actions taken. Okay, there were some changes from the final rule, from the NPRM to the final rule. Again, I would emphasize it has been your feedback, it has been your discussion, it has been your comments that have shaped this final rule, and these next slides will tell you what major areas were changed. We had a phrase, disability-specific complex, inside of the NPRM. Individuals thought that that meant, in some cases, that a program or a residence that served 2 individuals with a shared disability, such as autism, would automatically be eliminated from funding. That was never CMS's intent. We looked at that based on the broader interpretations we were receiving as part of the comments, and we restructured the phrase to say any other setting that has the effect of isolating individuals receiving Medicaid HCBS from the broader community of individuals not receiving Medicaid HCBS. So we got to what the intent was of the concern of disability specific. With regard to rebuttable presumption, it's a legal term. It was in the NPRM. We modified that. The current language in the regulation says settings presumed to have institutional characteristics will be subject to heightened scrutiny, allowing states to present evidence that the setting is home and community-based. Again, I need to underscore that a state is not required if the state determines that a setting that is presumed not to be HCBS. If that state considers that setting not to be HCBS, CMS will not challenge that state. With regard to choice of providers in provider-owned and operated settings, we clarified that the choice of the provider, so I'm running a day program, and in that day program, I have a set of services. What we're clarifying here is that when the individual selects that site and that provider, they select the set of services that are inside that program, so that it would not be an expectation of CMS that that person would be admitted to your day program and then be selecting day program services from some outside entity to come into your facility or to your program setting. In much the same way we would not expect for an individual who selects a living arrangement with a set of services bundled in there to begin to attempt to procure those services outside of that setting. Private rooms and roommate choice, we clarified, as I said earlier, need, preferences, and resources are relevant. Providers must offer roommate choice for shared rooms. The requirement for a single room is a requirement for the state to ensure is available in the program, not for each individual provider. And with regard to the application of settings requirements to non-residential settings, the rule applies to all settings where home and community-based services are delivered, not just to residential settings. We have committed to providing additional information about how the states would apply the standards to non-residential settings. We are currently working on that. We have had a fairly exhaustive list of meetings with stakeholders and individuals knowledgeable or respected as experts in this area, and we have begun developing further guidance, technical guidance for the states. Okay, so the other piece that's going to impact programming would be service plans. The final rule includes a change to the requirements regarding person-centered service plans. Service plans must be done through a person-centered process. Person-centered planning is driven by the individual, includes people chosen by the individual, provides necessary information and supports to the individual to ensure that they can direct their process to the maximum extent possible. So if somebody doesn't have the full capacity to direct their plan, at what level do they have capacity and what supports are being brought to bear to ensure that they are able to do that. It's timely and occur at times and locations convenient to the individual. Again, person-centered means person-centered. It reflects cultural considerations. It uses plain language. It includes strategies for solving disagreements. It offers choices to the individuals regarding services and supports the individual receives and from whom they receive them, and it provides a method to request updates. It must reflect what is important to the individual, and the delivery of services must reflect personal preferences. They must ensure health and welfare. The importance is to identify strengths, preferences, and needs, both clinical needs and support needs, and the desired outcomes of the individual. It could include whether the services are self-directed or not. Many states offer self-direction. It includes individually identified goals and preferences related to relationships, community participation, employment, income and savings, healthcare and wellness, education, and others. It must include risk factors and what the measurements were put in place to minimize risk, backup plans where necessary. The individual is important to supporting the individual. The person's responsible for monitoring the plans. Must be distributed to the individual and anyone who is involved in the plan. So if you are offering a non-residential service to an individual, you should have a copy of the plan. It includes who purchases and controls self-directed services. It excludes unnecessary or inappropriate services and supports, and that is also an important area that should be looked at. If a state is providing services for an individual at a higher level of development and then begins providing services that would, for instance, let's take as an example, the state is providing supported employment services, and then the individual begins to receive pre-vocational services. There would be a significant question about whether those pre-vocational services were necessary or appropriate based on the fact that the individual had been in supported employment and had established a history for being able to work in a supported employment environment. These other provisions I've already covered, but they're certainly here for you to look at. At the bottom of this page clarifies guidance regarding effective dates of waiver amendments, particularly in the area of substantive changes. Essentially what we said is there is a substantive change, there can be no retroactive approval, it can only be prospective, and a public comment period is required. So if a substantive change occurs in a waiver, the state must open it for public comment. We've already discussed this with regard to the target group. If it's helpful for individuals, the target groups are individuals who are aged and disabled or both, individuals with intellectual disabilities, developmental disabilities, or both, and individuals with mental illness. Note here that if a state does this, they must assure that the waiver meets the needs of each individual regardless of target groups. So this should not call for the elimination of day activities that meet the needs of individuals to become to be lost in the inclusion of multiple target groups inside of a specific waiver. So for instance, if a day activity allows for individuals who need cognitive therapy to receive cognitive therapy, it would be our expectation that that service would be found in the multiple target waiver as well. Again, we've talked about this already, substantive changes. If there are substantive changes, you must go through a public comment period, and we will not approve a substantive change retrospectively. What I'm going to do now is I'm going to slow down and take some questions. We have here essentially what is in a 1915C and what is in a 1915I, which is the remaining slides. I'm not quite sure that they will be vital to our discussion here. If we get questions that appear to reference points inside of there, we will highlight them for you, but we wanted you to have the full packet so that you would have reference points if you go back and need to ask additional questions on the C or the I. Can we go ahead and open for some questions at this point?
Yes, I think so. And again, thank you so much, Ralph. I think that was a great overview, and I know we've got a ton of questions. So I just want to kind of go through several at a time. The first question I'd like to pose to you is whether or not what disability-specific settings would meet the criteria for being home and community-based as defined on slide 9.
Hold on, and let me do a what we're looking for is not necessarily whether the setting is disability specific or not. What we are looking for is, does the setting have these characteristics? Does it support access to the greater community? Does it provide the opportunity for individuals to seek employment if appropriate? And I need to be clear that our position is that individuals should be in employment and that individuals have the right to employment if they so choose. That all of these characteristics in here, Serena, are characteristics that should be present in the setting in order to support a finding that that setting is home and community-based in nature.
Thank you. Another question we received is about the provision of services in apartment buildings, and I'll read the exact question for you. We have providers delivering services to home and community-based service recipients in apartment buildings with 8 to 16 individual units. How does CMS view these settings in regards to the characteristics of an institution? Would this type of setting be considered integrated?
It depends on what that setting looks like. Again, the answer is that, for instance, you might call that setting, the state might call that setting home/apartment-based services. I'm making this up now. But home/apartment-based services could mean that there's a setting here where individuals don't get out. All services go into the individual, and the individual does not integrate into the greater community. Another setting may be one where the individuals go out on a regular basis into the community. They're fully integrated into the community. The services that come into the setting work on integrating the individual into the community. So it would depend on the qualities that are existent inside the setting and how those qualities support integration. So the bottom line is it goes back to the experience of the individual. Is the individual sitting inside of four walls waiting for everything to come to them?
Mm-hmm. Okay, excellent. I have several other questions about...
I just need to say here, again, the caution. Remember that there are other criteria. So also, is that setting adjacent to or on the grounds of a public institution? So there are other pieces that you have to look at when you look at the full implications when you're looking at a setting. I'm sorry, Serena, I didn't mean to interrupt.
Not at all, not at all. That's fine. Thank you for that clarification. This next question was submitted prior to the presentation. I think that you've touched upon it, but I think it might be important for you to reinforce this. One of the questions was, does the setting requirements for employment and day services prohibit the provision of day habilitation in a residential care facility?
Yes, actually it's in our current regulation, not the new regulation, but in the current regulation, that states that day habilitation services must be provided outside of an individual's residence.
Thank you. And does the setting requirements for employment services or day programs prevent an assisted living facility from being on the same property or adjacent to, such as across the street from a nursing facility? What about a day habilitation program or an adult care program, daycare program?
The answer to that would be that it depends. Is the nursing facility a public facility or a private facility? Remember, the language on adjacent to or on the grounds of is specific to public institutions. It does not necessarily mean that that setting meets the requirements. If they don't meet the characteristics, they don't meet the requirements. But it does mean that they do not automatically fall into the bucket of presumed not to be HCBS based on their location. If they isolate, they certainly could fall into presumed non-HCBS, but that would be the characteristic and the trait that the state would be discovering upon review, not what it is adjacent to, unless, of course, it is a public institution.
Okay, thank you for making that distinction.
I hope that's clear, and folks may need to look at that and think about that some more, but that is a distinction that people need to be aware of.
I agree with you. That question was submitted numerous times prior to your presentation, so hopefully after today folks have a better distinction in their minds, but they may need to look at that part of the rule a little more carefully.
We understood when we created the language there that there were settings where, for instance, married couples or partners who had been together for their life, one was now declining and was in a more restrictive setting, and they wanted to be located close to that person. And we fully support that. The question is, the individual who is not in that type of setting, how are they accessing the community? They should not have to give up their church, their community, and their outcomes because they want to be close to a loved one.
Mm-hmm. In last week's webinar, it was noted that day habilitation or adult daycare settings that are exclusively for people who are elderly or folks with disabilities would not be considered integrated. Could you please expand on this?
I don't know what discussion is being referenced. I certainly did not make that distinction. Again, we've said that we are not, there is nothing in the regulation that says that you can't have disability-specific settings. It says that the individual must be integrated into the larger community and that the at the same level of individuals who don't receive Medicaid services. So absent a locale that is problematic, an absent location inside of a public or private institution that renders the inpatient treatment, the question becomes, does the setting two questions actually. Does the settings have the characteristics required for home and community-based, and does the setting isolate? I can tell you if the setting truly meets the requirement for integration, it should not isolate. I hope that.
Yeah, I think that does. Another set of questions came in that I think you clarified pretty well. Around the evidence that has to be presented to establish something as home and community-based. One of the questions that we had is a two-part question. One was, the first part was, who makes that determination ultimately? And the second was just a clarification. I think I heard you say if a state considers a setting not to be home and community-based in nature, CMS will not challenge that decision. Is that made by the state? Is that an accurate reinforcement of what you said?
Pretty much. Let me go back to your first question and see if that helps.
Okay.
Your first question is, what type of evidence will the state submit, I think?
Mm-hmm.
Who determines what type of evidence?
Who determines, right.
The state determines it. The state determines it based on the assessment they do of whether the setting falls into the presumed not to be HCBS. If the state determines that the setting falls into the presumed not to be HCBS and the state determines they want to present evidence to argue that it is both HCBS and that it is not institutional, the state would submit that evidence. CMS would determine through heightened scrutiny if the evidence was adequate and sufficient enough to support that state's contention. So there are like two answers to your question.
Mm-hmm.
But it's all in the process of how it occurs.
Okay. I'm going to switch over a bit to some more mechanical questions that have come in. One question is, will the new HCBS rules apply to 1915B waivers that are concurrent with 1915C waivers?
Okay, here's the answer for that. The controlling authority for settings will be the 1915C. And the 1915C is covered under this regulation. So the answer is yes. The answer is yes because the controlling authority for settings is the C authority.
Okay, great. Okay. Lots of interest. We've received a lot of questions around the transition plans, much of which I think you clarified in your presentation, but here are some additional questions. By March 17th, 2015, can states submit a transition plan collectively for all waiver programs and state plan programs, or must the transition plans be submitted separately per waiver?
Okay, the answer is this. A state must, in any renewal or amendment, include the portion of the transition plan that covers that authority, because the state has to be telling us how that authority is going to comply. Within the first year, when they've submitted an initial renewal or amendment, they have to include the transition plan for that renewal and amendment, and 120 days later, they must submit to CMS a statewide plan. The importance of this is to ensure that states begin working on transition plans at the beginning or as early in this 5-year cycle as they can, because there is a maximum of 5 years to be fully compliant with the rule. And that is that time frame, although it would appear to be fairly generous, is tight, and specifically tight for day programs. So what is included in the transition plan will be based on where the state is and how early they have to submit their first plan. But there will be a statewide transition plan, and after the statewide transition plan is approved, any 1915C or I that comes in for amendment or renewal after that, that portion of the transition plan that is specific to that authority should be integrated into that authority's application.
Okay, great. We also have some questions around, it says, can you give us more information on the process that CMS will follow to approve the transition plans? Should we expect a process similar to renewals and amendments with RAIs, et cetera, or is it anticipated that to be less formal and left up to the state more?
For the transition plan that is waiver specific or 1915I specific, it will go through the normal 90-day clock, IRA, informal request for additional information or request for additional information process. It is part of and embedded in that document. For the statewide plan, there will be no clock ticking other than the clock that says that the state needs answers so that they can begin work and begin facilitating this change. So you should expect discussions with CMS, regional office and central office, during the course of their review of the statewide plan and negotiations regarding what may need to be amended in it or what may not be amended in it. Certainly we could be approved up front and specifically, I would tell you, target areas would be where the public comment is not congruent with the state's assertion in the statewide plan, and or where CMS has information from advocacy groups, from the Department of Justice, from OCR, from some other source that cites problems or difficulties or issues of compliance that the state does not cite. There will be discussions with CMS, but it will not be a formal request for additional information.
Okay, thank you. I'm going to transition over a little bit to, no pun intended, to some additional questions around day and employment. And understanding that, as you noted, you all are working on some additional guidance to the field around some of these issues, so you may not be able to answer them all today, but I think it's important to at least share many of the questions that we're getting. One of the questions that we heard in a number of different ways is, is there a test or is there some basic criteria that states should be making in terms of determining what is enough community interaction? So in other words, if pre-vocational, if home and community-based services were funding an entity that's providing services both in a segregated and community-based setting, depending on the time of day, how would you look at that? For example, pre-vocational services. Someone's receiving some pre-vocational services in a segregated setting, but then maybe in the community during part of their day receiving day habilitation services. Is there a basic test or some criteria that states should be looking at and trying to make those determinations?
There are, I'm going to say several things on that. One is that we are developing additional guidance, as I said earlier, and that is one of the questions that has been asked and has been a driver in considering what type of additional technical guidance we could give to states. Today, I'm not prepared to give you a complete answer to that, and part of the answer is that we expect and anticipate that some states will already have developed some criteria for this. I think it is an important question because certainly your day activity, even at work, is different than your day activity at home. But that there is a measurement of community involvement and community access is, I think, a significantly important part of determining whether or not the program will meet the characteristic settings. One of the things I will say is that there is a checklist coming out as part of a toolkit that we should have released before or on March 17th, but the non-residential will come later. But you could take some of the stuff in this toolkit and apply to non-residential. Certainly you're applying the characteristics to non-residential. So, for instance, one of the questions we ask when it comes to residential programs, where the integration question is asked, is when you are doing an on-site visit, do you note that people are walking across the street when they reach the facility? Or is there street traffic in front of the facility? Do individuals go in and out of the facility? Do people walking on the street say hello? Do they respond to them? Is there interaction going on? And I think that that also would apply even in a day service setting. Is this an isolated setting where people just don't interact, literally walk across the street because they know this isn't a community setting? Or is it a setting that encourages community interaction? That's the best I can give you for now. I'm sorry, we are developing deeper guidance.
I think that was helpful, and I'm sure you all would be open to a follow-up webinar once there's additional guidance out in the publicly available to answer some of these more specific questions around that, because I know we have a lot of folks that are really interested in getting as much clarity and direction from CMS as possible and making some decisions around how they're going to establish what meets the rule in their own states with respect to provision of day and employment services. We did receive quite a few inquiries around the person-centered planning process as well.
Sure.
And I'd love to ask you a few questions about that. The first is really, I think, more of a cautionary remark or question about how will CMS ensure that the person-centered planning process is not coercive, or that it's not that it's transparent and that it's protected from outside conflicts of interest. And you know, I thought a lot when I looked at this question about the great criteria that CMS requires the BIP states, the Balancing Incentives Program states, to meet in order to receive that increased FMAP rate. And one of those is conflict-free case management. And I would, well, I'll let you answer the question, but I would assume that those types of elements are things that you would want to be encouraging states to think about in trying to avoid having a person-centered planning process that lacks integrity.
Well, even the guidance, current guidance in the C talks about the fact that case management services should not be provided by, or plan writing services should not be provided by somebody who is providing additional services to the individual. The only exception is where that is the only provider in the area, and then there is a requirement that firewalls be set up to ensure that that function is conflict-free. So I can tell you that the current guidance inside of the 1915C has a check for that as well. But I think that it goes deeper than that, and I think that it is not simply a signature on a page. Although, need to be clear that there are some things, one of the reasons we required that the plans be signed is there are legal implications when you sign a plan. That being said, we expect and anticipate that states, on an ongoing basis, monitor service plans. It's part of the expectations of the 1915C waivers and part of the expectations of the 1915I, and that the state would ensure that the individual's needs, it is a basic requirement and a sub-assurance that the state has to report on, that the individual's needs and desires are being met and have been considered in the plan. So it is our expectation that there will be a look behind. The state will report on that on an annual basis, and will report on that before renewals in an evidentiary packet. So there should and will be look-behinds to ensure that the individual is making a free choice. I can also tell you as a state administrator for some years that it was one area where there were certainly federal and internal state audits that looked to ensure that the individual had freedom of choice and how that choice is documented. Remember that the plan of care must include what options were available to the individual to select from.
Thank you, Ralph, for that. So there's another question here that kind of speaks to a different side of self-direction, and that is, if someone, through, I think your statement was free choice, actively continues to choose sheltered workshops or segregated day habilitation programs, is it the view of CMS that eventually Medicaid funds have to stop funding that at some point, or are states encouraged to think through a phased-in process or revisiting of their reimbursement rates? How do you look at those individuals who make those free choices, I guess?
Wow, there's a lot of question in there, and I do mean that. There's nothing facetious about what I'm saying. We do not anticipate that any state would force an individual into a setting that the individual did not want to have services in. That being said, we also do not anticipate that a state will bill for federal funding participation for a setting that does not meet the characteristics of HCBS within the next 5-year period phase of the transition plan. And I need to be clear here, a state could do a statewide transition plan that is only going to take 3 years. We will not force that state to go to 5 years. 5 years is the maximum amount allowed. So I need to be clear that when I talk about state-specific, I do mean state-specific. If the individual chooses to remain in a setting that is not HCBS, there will be no HCBS funding beyond the time the transition plan exists. The state will need to determine whether or not the state is going to continue to fund a service that they cannot draw down FFP for. But that is an area that CMS would not be involved in. It is out of our purview.
And I think it's important to also understand the reason why the individual is choosing to stay in the sheltered workshop. Is it because of the friends that are there that they've known for 30 years? And if so, what kind of relationships could be built outside of the sheltered workshop? Is it the money that they're making? I doubt it. And if so, that there's plenty more money to be made out in the private sector. What's the rationale behind why they want to remain in the shelter workshop? And again, people have to have exposure to multiple different opportunities in the community in order to make a really good informed choice, just like you and I did before we made a choice of what career we were going to be in. You know, we probably worked 2 or 3 different jobs, perhaps at a fast food joint or at a nursing home or whatever. I'm giving away my resume. Before we finally landed in our career. So people have to have that exposure and that opportunity to experience life the way we experience life.
Excellent points. Thank you very much, and just excellent response to a very difficult question. Just noticing the time, I think we have time for about 3 more questions, and I want to shift gears again because we did receive some very important questions on the very exciting world of outcome and performance measurement. So I'd like to kind of make sure we get a couple of those questions in. One of them was, can you address more specifically the outcome-oriented definition of home and community-based settings and how it relates to non-residential settings? And I'm going to just include with that a second question because they're pretty similar. What performance measures will you be looking for from states to measure compliance with respect to day and employment services?
Well, again, another interesting question. When I talked about outcome, I talked about an outcome-oriented definition. So the definition itself is outcome-oriented in that it no longer looks at whether you are an institution or not. It looks at what the experience of the individual will be. If you go back and look through the characteristics, provides opportunity to seek employment, is integrated in and supports, ensures the individual receives services in the community to the same degree. Those are all outcomes, and they should all be part of the original measurement that a state uses to determine whether a setting meets HCBS or not. I think the question here is, when the state determines that the setting does not meet HCBS but could meet HCBS with modifications, how are those modifications and how is the final outcome measured? The final outcome is measured through milestones and timetables that the state gives to CMS for approval and evidence that the state will or can produce to demonstrate that when the milestone has been, when the time frame for the milestone is at hand, that the facilities that were identified that will have gone through the changes necessary to comport with HCBS now can demonstrate the characteristics similar to the ones. These are just a few of many that I pulled up on the screen, but that the settings have been sufficiently modified and structured in a way that now meets this outcome-oriented statement. The other piece that I will remind you is that inside of a 1915C and a 1915I, there are quality assurances. There are basic assurances and sub-assurances the state must report on an annual basis, and I'm not talking transition plan here. I'm talking just quality outcomes. And they include measurements of service plans and measurements of providers and whether or not they are qualified and meeting. This certainly would be, I would think, for a healthy state that was considering how to get some administrative and economic efficiencies, a way to dovetail measurements in a manner that ensures that they're looking at the total picture and doing it as efficiently as possible.
Excellent. One final question. We received a lot of inquiries related to training requirements, and any recommendations that CMS has or requirements they will have in terms of state investment and prioritization of ongoing training, technical assistance, and professional development of frontline staff, many of whom have been working in more traditional segregated models for some time and may need to really enhance their skills and get additional ongoing mentoring and support to be able to deliver services in a more integrated setting. So any final thoughts related to that particular topic?
I will tell you up front that CMS has not mandated that, but it sounds like a lovely transition plan. As I'm listening to you say it, I'm going, I could see that as an approvable transition plan with milestones for when staff working in a facility that, for instance, is very regimented and very time-oriented, where things have to be done at specific times and go by schedule, that that would be a great plan for addressing those issues and demonstrating how to meet individuals' needs, and to begin working on an individual basis and begin working on a community integration strategy in a way that allows the facility to move from not currently meeting to meeting HCBS settings. So while we haven't mandated it, I certainly would be surprised if we don't receive similar types of intervention strategies in state transition plans.
In fact, I think it's key. You really can't do really good transitioning, and I'm speaking from the provider's perspective of shifting a sheltered workshop to employment services. You really can't do good, solid services unless that day staff has that foundation and that grounding in integrated services. So it really is instrumental. We don't mandate it, but it's instrumental.
I'm so glad I asked that question, because I know there are so many state folks on the line right now thinking about their transition plans, and I think that was great direction you gave them and suggestions that they think about including this into their transition plan. All right, I told you that was my last question, but I have one more that came up that I thought was really good, and that is CMS considering adding specific assurances or sub-assurances to ensure states are in compliance with the new HCBS setting requirements?
There are a couple places that we're looking at in the applications, but the interesting thing is this: when I answer this question, or when people ask me this question, it always prompts me to remind states that for years they have been answering a question regarding facilities that fall under Section 1616E that says, how does the state ensure home and community-based in this setting? And the state has, on an ongoing basis, delineated in their application how they do so, just as states have delineated what their public input process is. So while these are required portions of the regulation, they are things that the states have been doing over time. What we've done with this regulation is to actually give you firm and regulatory guidance on what you are looking for. But those places where you would respond, in many cases, already exist in the current policy and process. Like I said, for person-centered planning, the monitoring of service plan is required as an assurance and a sub-assurance. I can also tell you, just as an aside, because it's not specifically with regard to this regulation, and isn't regard to this regulation at all. As you know, CMS has always embraced a continuous quality improvement process since 2002. There will be an informational bulletin coming out imminently that will introduce sub-assurances in areas where the assurances were broad and states were asking for further direction or guidance about what they should actually be measuring inside of those sub-assurances. So there will be clarification regarding health and welfare sub-assurances, regarding fiscal sub-assurances, and we'll take a look. But those are already required. Those are already part of the 1915C and the 1915I programs.
And the other thing that I wanted to add, too, is that there will be monitoring that will happen of the transition plan that will occur.
So the state will identify milestones. If the state folds those milestones into their annual reporting of their on their 372s of quality, I could certainly see that as an area where a state could consolidate some administrative work and facilitate some ease of administrative activities. But then again, the state might want to pull it out and monitor it separately because it is so significant and so important to get to the end point in a time frame permitted.
Well, I don't know about anyone else on the call, but I learned a lot today, and I am sure that the 400-plus people on today's conversation also learned a lot. It sounds like there's a lot more coming down the pike from our friends and colleagues at CMS. I always tease them that they do not let much grass grow under their feet these days. So we will continue to collaborate with them and identify opportunities for disseminating information as additional guidance or sub-guidance comes out on these issues. At the same time, I want to end with the last question, which was, will this webinar be archived? And it will. This one and last week's will be up on the our National Lead Center's website at www.leadcenter.org in the next few days. Ralph, did you have something else you wanted to add real quick?
I moved the webinar forward to the last page to make sure people saw the resource addresses. There is information on the regulation at www.medicaid.gov /HCBS, and I can tell you that more information will be going up there. So that is a website that I might mark as a favorite if I were interested in following up on this regulation, and that I have marked as a favorite. And if you have additional questions, this is the site for the questions, the mailbox. Know that it is not likely that you will receive an individual response. What we are trying to do is to take the questions as they come in, bucket them to see, as you did today, it appears, how many questions you received on a specific area, and then get an answer on that in that area. And we will be putting out FAQs based on the questions that are coming in. Of course, if you have a state-specific or a specific question, this is not necessarily the website I'd use. I would contact my regional CMS contact person to have that discussion. But this website, this mailbox is open for questions as well. Okay?
That sounds great, and I'm assuming you all have been doing a lot of work to educate the regional offices and staff as well, so that when they get those questions, they'll be readily armed with accurate responses for these states, correct?
And we will work side by side with them. It will surprise me if, as the calls come in, the regional office isn't immediately contacting central office as well.
Fabulous.
So, yes, working closely with them.
Well, thank you again. On behalf of ODEP, I want to thank our colleagues from CMS who have just exemplified fantastic public service and leadership in our federal government. We really appreciate your time today, and we appreciate everyone's time for those that came in. Again, this webinar will be archived at the National Lead Center's website at www.leadcenter.org. It will also be on ODEP's website in the near future. So again, we look forward to continuing our work on systems change activities in the states, and we hope that you enjoyed today's webinar. Thank you all very much.
Thank you. Goodbye now.